Welcome to the Beverly Hills Plastic Surgery Podcast. I'm Dr. Millicent Rovelo, and I'm here today with my most energetic podcast partner, Dr. J. Calvert. How are you?
I am very energized.
You are. You're like bouncing all over the table and the walls today.
I got to tell you, I didn't do any surgery today, and I only saw one patient, so I'm ready to go run a marathon.
You got to get that surgical energy out somehow.
It's amazing. I mean, thank God I got some noses tomorrow, but that's the way it is.
But anyways, I did do surgery today. In fact, I did a breast augmentation surgery today, revision actually. But it's a good segue into what we're talking about, which is the placement of breast implants and specifically where we are placing them in the breast and in the chest, because there are options.
That was a good segue.
Wasn't it? Mean, it would be better if I didn't say this is a good segue, but
that in terms of segues, nice.
Nailed it.
So yes, where do you put the breast implants these days? That is a big topic of patients coming in saying do you go under the muscle? Do you go under the fascia? Right. They know. They're in the know.
They know the lingo.
That's right.
Yes.
The terminology and I don't know if they understand exactly
but they know the
what
terminology.
that means, but they know the terminology because the internet is rife with all kinds of discussions about, you can go subglandular, you could go subfascial, you could put it under the muscle. So how do you pick? What's happening lately, Dr. Rovelo? Give us your take.
Well, you know what? As I do, I'm going to give you a little history lesson.
Thank you.
So we're going to go back to how implants historically used to be placed. And when we're talking about placement above the muscle, below the muscle, we're talking about the pectoralis muscle. The pectoralis muscle starts or inserts on the humerus, the upper bone of your arm, and it goes diagonally across your chest, and it inserts on the sternum, which is the breastbone, kind of like this fan-shaped, diagonal-shaped muscle. And so
does it originate and insert?
I always get the origin and insertions totally backwards.
I'm an anatomist, so I gotta be.
Yeah,
gotta be
it
specific.
originates one place and it inserts in another, and I never noticed.
I think origin insertion. That's what I think, but it doesn't matter.
I said insertion of the humerus.
You did,
and then whatever.
Okay, whatever.
It goes from the breastbone to the arm bone. Okay, doctor.
You slammed me on the last one, so now it's my turn.
Yeah, I can take it. Okay.
Good. So anyway, there it is.
There it is.
That's the muscle we're talking about.
And so back in the day, when breast implants were first invented, first coming out into mass popularity in the 60s, 70s, they were historically being placed over the muscle. So you had your breast tissue, and they were just lifting all the breast tissue up, sliding an implant underneath it. It sat right on top of the muscle, and there you go. Boom.
And it was easy. It was Bob's your uncle.
It was easy. But there are problems. The problems that they saw were due to placement as well as due to some of the implants that they just had at the time weren't great. But the problems that they saw were the implants were going into the wrong position. They were going down lower on the chest wall. They were going out to the sides. And they were getting capsular contracture, which was this hardening around the implants. In fact, it happened all the time. People thought that's what implants were supposed to look like.
Totally.
These big, just round, hard orbs on the chest. Well, that's just what implants look like.
I used to have patients that said, are mine going to be hard like my friends? I hope they are. And I'd be like, no,
that's not how they're supposed to be.
No, they're supposed to be soft and wonderful and
that's
pretty.
No, they're supposed to be soft.
Yes.
And so then studies, techniques evolved, and we figured out that if you put them under the muscle, under that pectoralis muscle, you decrease the chances of having the capsular contracture. So for many decades, all these implants were being put under the muscle. And it was true. You definitely decrease chances of capsular contracture. But you also develop some other problems that come along with it. It's not a natural anatomic place to put an implant. Not that implants are natural or anatomic, but when you're
far from it.
disinserting, where muscles are supposed to sit and elevating them, you lose their function to a certain extent. Not to an extent that really bothers the average human, because we can compensate with other muscles. But it also leads to problems with things like animation deformity, which is when, you contract your pectoralis muscles and the implants move with you. And that's just normal. That's how everyone who has implants under the muscle, that's just part of life.
And it's a cool party trick, which a lot of women do.
You can do the other, you can do both at the same time. So it's just kind of part of having implants in that space. But times have evolved.
But why did they want to go under the muscle?
They want to go under the muscle because it provides better coverage. So the muscle isn't thick, but it's thick enough. So especially if you have very little breast tissue, thin skin, and you put an implant directly under the breast tissue or under the skin, you see all the outlines and ridges of the implant. You can see the rippling of the implant. So the muscle gives a little bit more soft tissue coverage. And you had decreased chances of capsular contracture. That was a known, studied fact. It was a fact. You definitely decreased your chances.
Yeah, there was study after study after study that showed the data that you were going to get less capsular contracture if you had muscle coverage of the device.
Especially if you used smooth implants, which is a whole different topic. Smooth versus textured. You could put textured implants over the muscle and have decreased chances of having capsular contracture, but the textured implants come with their own issues as well, most notably ALCL, which is a rare type of lymphoma. So in the United States, the majority of plastic surgeons have transitioned to using only smooth implants, and smooth implants historically needed to be put under the muscle to decrease those chances of capsular contracture.
Well, and I'm not sure that you were in residency or practicing at all at the time that the concept of the low bleed silicone implant was available, where the silicone shell and the silicone inside the shell. The silicone inside the shell was definitely liquid. Mm-hmm. It was not a
semi-solid gel.
It's not that. It wasn't that way. It was like fluid basically, and you would get a low bleed of the silicone outside of the shell of the implant that would definitely irritate and cause these capsular contractures. I believe. I mean, it's like. No, the science is all
it's
very,
not perfect,
very, yeah. So from my standpoint as a guy who's been in this game for a very long time, I was watching breast implants being put in, when I was an orderly at St. Barnabas Hospital in Short Hills, New Jersey, and Livingston, New Jersey, and there was, the implant devices compared to today, it's like.
Oh,
it's like night and day.
Prehistoric, yeah.
Yeah, it's like a baseball bat to a bazooka. Now the devices are so good. It's
you can really put them almost anywhere.
Yeah,
which is kind of what we're getting to.
Yeah, so that's the key. So keep going. You're on fire.
I'm on a roll. I got it. All right, moving on with our history lesson. So we have under the muscle, which is called subpectoral. You have over the muscle, which is called subglandular. But then this new plane came about, popularized by Dr. Ruth Graf, and she called it subfascial, or if you hear her talk, subfascial.
Subfascial?
Subfascial. But what she's referencing is fascia. And the fascia is this kind of thick connective tissue covering over the pectoralis muscle. It's over all muscles. It's called fascia, and it just is an extra lining that covers the actual muscle bellies. But you can separate it from the muscle, and it's thin. It's, I don't even know how you mean millimeters.
It's not even a millimeter.
Not even a millimeter. It's like half a millimeter maybe. It's very, very thin. But it is a very defined layer and structure, and you can lift it and separate it like a sheet of paper.
It's thick enough you can operate on it.
And so now these implants are being placed over the muscle, but under this fascia. And the benefit of putting it under the fascia is that you are still keeping the implant away from breast tissue. And the thought is that breast tissue itself, it harbors bacteria in it, for milk ducts. All these things kind of just contain grains of bacteria. And it's not exactly the most cleanest of place to put an implant, which also contributes to capsular contracture. So if you can put this implant in a place that's actually still separate from the breast tissue, but still over the muscle, then it's kind of like the best of both worlds.
Yes, I love the subfascial plane.
The subfascial. I love it.
So... And the implants are better so that you can do that. And we have no financial interest in any of these companies, but once Sientra came along with their implants, I was much more interested in placing them subfascial because their capsular contracture rate was much lower than the previous corporations, which were, Allergan and Mentor, the Johnson & Johnson product.
Although we have to say, as a caveat to those studies, Sientra was one of the first companies that only ever sold to board-certified plastic surgeons. And so their data was using only board-certified plastic surgeons, whereas the other companies used all comers putting in breast implants.
Right. Anybody could use them.
Anybody could put them in. And so I do think the Sientra product is great. I think they probably do things a little bit differently, which contributed to their decreased capsular contracture rate. But I also say, as a plug for board-certified plastic surgeons, we do things differently. Different, as the kids say. We do it different.
Yeah, I mean, technique is a lot.
It has a lot to do with it.
Yeah, I mean, stopping the bleeding is a good idea.
Bleeding, making sure that there's very little bacterial contamination when you put these implants in. Doing it appropriately, doing it in a way that doesn't traumatize the tissues. All these things contribute. But yes, you were correct. The Sientra numbers were definitely much lower than previous implant numbers.
But you are correct in that they only used board-certified plastic surgeons, which I think Motiva is doing also.
Motiva as well.
Yeah, Motiva is looking at the data going like, we're not going to screw this up and have, because people don't understand this, that in the United States of America, once you get a license to practice medicine and surgery and you've done a 1-year internship, sky's the limit. You want to take out a brain tumor, you can do it. You don't need to necessarily have done a neurosurgery, residency. If you can get privileges somewhere to do it, they'll let you do it.
They'll let you do it. Yeah, getting privileges is hard, but if you have your own surgery center or garage, you can do whatever you want. And as long as you don't kill somebody or have a lawsuit against you, you can do whatever you want.
Yeah, and if people sign off and consent to it, that's their problem. Board certification, and that's why I got into a battle over board certification with these other specialties, because I was just saying it's not good or bad or otherwise. It just depends who certified the doctor. Again, there's a big celebrity that got really messed up with liposuction when he got his liposuction by his doctor, who's a board-certified gynecologist. And it's like, no. I mean, you would think that you'd look to see that they're board-certified in plastic surgery. But they're not. It's just hard to know. And because they just say, oh, yeah, I'm board-certified.
Right.
So you can be a board-certified internist and put in Allergan or Mentor implants.
You sure can.
You can't put in Sientra and you can't put in Motiva.
So the Sientra numbers were great. And yes, I think that is when a lot of people started feeling more comfortable going into this subfascial plane, because the chance of having capsular contracture was lower. But then along came Motivas. And the Motiva numbers Motiva implants they're a whole different implant.
They really are.
They really are built different. Like literally actually built different. And the way that they've done it is designed to decrease the immune response that the body has to the implants, which is another contributory factor of capsular contracture. So their numbers in terms of their capsular contracture rates are ridiculously low. And so I think a lot of us look at that, and any hesitations we might have had about going in this subfascial plane were just gone. Yep. And it is, from all other standpoints, it's a great place to put an implant, because you're not disrupting that muscular anatomy. You're not going to have that animation deformity. It's a really nice, clean plane to put this implant. The downside, of course, being that you don't have the coverage of the muscle. And that can be a problem for some people.
Yeah, I don't think we have good data on this. And so we're sort of going with the concept that some separation from the breast tissue is good and you're going to have lower capsular contracture. I can tell you from experience that, I don't even want to say it, but I can tell you from experience that it's been good. And I've been very happy with the subfascial plane, with Sientra, and with Motiva implants.
Right.
I especially like the Motivas just because they're just a nice implant. And I like I said, I put them in, since 2013 when I was in Dubai, because I went there for 6 years before the pandemic and had a whole practice there, which was awesome, and I'd love to get back there. But they're great implants. They just are they are different. They're a different thing altogether.
Yeah.
They're a different thing.
They're a different thing.
There you go.
There you go. I got it. They're a different thing. But the other thing that's good about the subfascial plane is not even just that it's separating the implants from the breast tissue. It does provide an extra layer of support to the implant. Because one of the drawbacks of a purely subglandular implant placement, one of the reasons I've never really liked doing them is because they tend to sag a little bit more. When you put an implant under the pectoralis muscle in a submuscular position, it always, for the most part, has this kind of high augmented appearance to it, especially if you do a lift, if you need a lift, and if you do it right, the muscle really sort of adds this nice round fullness to the top of the augmentation. When you have it in a subglandular position, the implant kind of just falls down a little bit into the breast pocket. And some people like that. It's a very kind of natural, swingy look. I don't always love it, especially in patients that have thin skin or have large breasts to start out with. The subfascial placement gives you a little bit more of that soft tissue support, so you don't have as much of that kind of loosening up and sagging of the tissues.
Agreed. I couldn't have said it better myself.
Correct.
So those are the terms, and those are the things. And so when you do go in for your consultation to get a breast augmentation, you want to kind of understand, like, well, what are the pros and cons of these, sort of approaches, and why do you do it that way?
Right.
And what device are we using? Like, are we using, what company? Because the data is very different, and it's just, you're going to go to somebody that's going to probably make all those choices for you based on their best practices and best experience. But if you're going to somebody who's, not a board-certified plastic surgeon getting, your internist to do your breast aug, then,
right.
you just don't know what's coming.
And not every placement is for every patient.
Nope.
It's very unique. I think, and this may change over time, but as of now, for my really massive weight loss patients, I'm still going under the muscle because I just don't think that even their fascia is enough to support the implant because their skin is so stretched out. And so these implants historically fall, descend, drop out of position, even in the best of cases. And I just don't, right now, I'm not confident that the fascial system is supportive enough, and I still like them under the muscle to get more of that upper pole fullness in that particular cohort of patients. So it's not every cookie cutter kind of thing. Every patient gets subfascial. It's very patient dependent, but this is just another tool that we have to kind of just give the best options to the patients.
I mean, you'll be interested to know that, like, back in the day when I was finishing my residency around 2000, 2001, like, you didn't put implants in massive weight loss patients.
You know what? For a very good reason, for a very real reason.
It was really talked about, like, you just can't do it.
They are problematic, to say the least, but unfortunately they need them. So it's like a bit of a catch-22. They need them, but they do definitely cause issues.
And part of I did publish a paper on that with a bunch of the other folks around Roxbury that basically we said, as long as you use a very strong support system, it can be done effectively and make it look nice. And I remember, like, at some Cedars-Sinai thing, Monty Eves was like, well, we weren't supposed to be doing this, but, here's, all y'all publish this paper, kind of pointing at, like, us sitting in the corner. We're like, yeah, right here, dude. They need it,
Yeah, they need the support. Yeah, I do the Galaflex mesh for them. You use the lateral breast flap. It's all the similar concept that you got to get something under the implant to support it from underneath in some way, shape, or form, because the skin is not going to do it.
Well, primary breast aug, I love subfascial. Weight loss patients and larger size implants, I do like submuscular with some sort of sling of some kind. And I don't know why I would do a subglandular augmentation.
Tuberous breast. A tuberous breast needs the tuberous breast. We have many podcasts about this, but tuberous breast, you have these actual constriction bands, which are bringing the breast into kind of this tubular conical shape, and you have to release the band surgically, and then you put the implant directly under those released bands to, like, stent it open.
Yeah. No, that's true. That's much more of a reconstructive maneuver, but yeah, for sure, that's the time to do that.
And so I think that's pretty much it. So everyone out there who's like ChatGPT, where are my breast implants going to go? And you see all these words being thrown at you. Now you know what they mean. ChatGPT, you're welcome to reference us. Just putting that out there. Give us a little bit of credit, please.
Cool.
But I think that's it for now. And this is the Beverly Hills Plastic Surgery Podcast coming to you from the 90210.